I'm all okay to.
Good evening, everyone. We welcome you back to our Scale Masterclass series, to the Advances in ART Masterclass series. We're very honored to have Sachin sir, who's made time to attend this morning. Sir is not in India, still he is making time to have this masterclass with us today. And so, as we know, the topic for today is going to be novel stimulation protocols. Before we introduce Sir, we just like to let you know about the Scale Fellowship programs. We have 1 year fellowship program in clinical embryology and 1 year fellowship program in ART. Anybody who is interested for good training with a lot of academics and hands-on sessions, kindly get in touch with us. Vasundara ma'am, I kindly request you to introduce Sachin sir for today.
Yes, please. Good evening, one and all. Again, it is a proud privilege and great honor to introduce such a seasoned teacher amongst us and who has taught generations and continuing to teach. And he's so passionate about teaching that today he sits in New York and then he's so committed that, sir is coming in a different time zone and teaching. So humbly, thank you so much for accepting and doing this part 2 of novel stimulation protocols. I'm sure whoever has attended the part 1, it was like, an extremely informative session. Basics of reproductive endocrinology and physiology. And then based on that, tailoring the stimulation protocol is very, very important. And for this, none other than Sachin Kulkarni sir will be guiding us through the entire stimulation protocol. Sir is a consultant at Sunanda IVF Kolhapur. He's the head of the Department Fertility and Reproductive Medicine at Jehangir Hospital, Pune. He's a teacher at Reproductive Medicine course at Dubai. He's a consultant New Fertility Center, Addis Ababa. Regularly conducts fellowship program in the field of IVF and reproductive medicine. Trained many students in this field and has got so many publications and presentations to his credit. Without much ado, I would welcome sir to take us through these part 2 of novel stimulation protocols. Mostly, I think sir would be focusing on protocols like random stimulation protocols, etc., etc. And we will see how things go by. We might have to, since the lecture is going to be exhaustive, if required, we can have part 3 as well. We'll be humbled to have you again, sir. Over to you, sir. Thank you.
Yeah, thank you so much, Dr. Vasundara and the whole team of Scale for making part of this academic activity. And every time we participate in an academic activity, really intrigues you to look into more literature, do a literature search, and find out what more evidence and how we can understand the subject better. So I've done that small bit, and I feel even today would be a little incomplete because I will be able to go through the basis of the random start or different kinds of novel protocols what we practice. I'm also trying to give a glimpse into why we use letrozole and why we use clomiphene and what does the evidence say today. Because when we say novel protocols, then that's the thing we are looking into. We are experimenting too much into novel protocols nowadays, especially for women who have advanced age, women with low ovarian reserve, or women especially who require multiple IVF cycles to carry on with their pregnancies. So it's very important for all of us to understand the evidences which have been published. And Dr. Vasundara, I'm so sorry that I won't be able to put in a lot of evidences today, but I'll try to put it in the next lecture because I just wanted to keep this short as well. Obviously, there would be a few repetitive concepts which we are dealing with, but I'm sure endocrinology is so volatile for all of us that we keep forgetting, and getting a reminder set for those concepts is always very important, and we become more mindful, more awakened in front of the client so that we can implement the right therapies to all of them. Well, allow me to share my screen. Okay, is my screen seen properly?
Yes, sir.
Yeah, I'm heard well also. Well, thank you again, Dr. Vasundara, and we'll start off with this bunch of slides which I want to put it across to you. The whole agenda is to talk a bit about the wave theories, talk about letrozole, the scientific background of letrozole, introduction into IVF protocols and clomiphene. We'll also go through a few papers therein, and also understand why we can start stimulations in different phases of cycles, how we can kick off the stimulation. I'm really thankful to Dr. Sharif for helping me out with this presentation, which we am presenting to you. What could be a true functional onset of a menstrual cycle? Don't worry, I'm not starting speed off here, but just a few slides like this. So it's actually a basal FSH signal which kicks off the follicle recruitment, and that signal is very minimal. It's hardly 2.5 MIU. And this is very difficult to measure due to long half-life of FSH of 24 hours or more, and multiple samplings will be needed. And it's really impractical, but for a research-based scenario. So we will never measure when the functional onset or the follicular phase has ever started in a particular lady. And we look at the LH surge, which is quite a measurable thing. And LH surge is but the end of the follicular phase. And it can be identified by a simple urinary dipstick method. And FSH baseline is pretty small amplitude and it cannot be recorded. That 2.5 high may not be recorded by all of us, but LH dipstick is positive and really certainly tells us the LH is surging and the follicular phase has ended. Since we do not know when the follicular phase starts accurately, we highly depend on other surrogate markers like the size of the follicle, estradiol levels, how the follicle looks, and we have so many signs which are telling us it's a pre-ovulatory follicle, so it is going to rupture soon. So we highly depend on those kinds of surrogate markers in our practice. Now, estrogen and progesterone inducing endometrial changes is very well known, all of us, basics. But what is the role of luteal estrogen? Now, when D. Ziegler et al. Did his studies, when he gave HRT page cycle, then he stopped estrogen completely, gave 5 days of only progesterone, and looked at the endometrial biopsy on day 6, and he said it is exactly the same as any other secondary phase. Then if progesterone alone is more than adequate, why do we need a luteal phase estrogen? And that's a physiological question we would like to ask and ask ourselves. So it is the estrogen, which is a drop in estrogen, is the primary factor which controlling the basal FSH signal. The moment the FSH E2 drops in the late luteal phase, the FSH starts rising. And menstrual period is solely as a result of progesterone withdrawal. And if the luteal estrogen is there or not, it does not make a difference. Like we see commonly in whenever you do therapies where you're giving estrogen valerate, estradiol valerate tablets, 4 to 6 milligram as a pre-treatment. You start late luteal. In spite of the lady having estrogen, the progesterone withdrawal is there, and lady will have bleeding in spite of the estrogen. That's why you are synchronizing your follicles further. So when we start our IVF stimulation on day 2, day 3, we really want to synchronize the rising FSH levels. And this is misunderstood actually, because the FSH level starts rising about -3, -4 days in most of the women with regular menstrual cycles, or maybe -7 for somebody who has low ovarian reserve or advanced stage women. And fresh embryo transfer is basically, we want to do a fresh embryo transfer, and then that's the reason we would like to synchronize with day 2, day 3 of stimulation, because blastocyst readiness and receptor endometrium match each other. But again, in many scenarios today, like PCOS, there's a risk of OHSS and diminished ovarian reserve with an embryo accumulation methodology, or PGTA cycles. We need to go multiple cycles. Our freeze-all policies have increased quite a bit, and we have stopped synchronizing our stimulation on day 2 or day 3 of the menstrual cycle. So the modern ART is all about oncofertilities, PGTA cycles, poor ovarian reserve with pooling cycles, PCOS, high responder on the go, or sometimes it could be a high responder on the go. Like you started stimulation, suddenly you see 20 follicles developing, and then you take a decision to do freeze all on the go. Then why not do freeze all for everyone? And well, I think this is a question going on in my mind for a pretty long time. And we just looking at so many evidences which have been published on the freeze all and fresh embryo transfer. And if you look at the Western evidence, which has been clearly says that only in high responder patients your freeze all cycles will work. Otherwise, your normal responders or your poor ovarian reserve patient doing fresh embryo transfer could be cost effective, saving, etc. And there were yesteryears when I was only doing fresh embryo transfers, maybe a decade back. Hardly any frozen cycles we did. But the problem we faced there was a choice. As a doctor, I never had a choice of selecting the best embryo, because whatever best embryo was developed in that particular cycle had to be transferred. Neither did our patient any choice of going for one more cycle and looking into the best embryo and transferring. And so we were compelled to do an embryo transfer because we were stuck to an attitude of a fresh embryo transfer. And obviously, a few of them will achieve pregnancy, and we were happy and proud about it. But at this juncture today, in 2025, I would say that, well, I would prefer free solve for everyone. I think I'm sure this is something which is debatable, and I would love any interaction and debate onto this. But what is the issue? There is an embryo endometrial asynchrony, obviously with low implantation rate. There is a dysregulated gene expression, implantation failure. There is early security advancement because of a high estrogen and progesterone coming up. Again, poor outcomes with fresh embryo transfer cycle. A high estradiol level will always shift the window of implantation and lower endometrial receptivity. And all that is very difficult to fractionate a lady. To have a certain number of eggs, certain number of embryos, a correct estrogen level, looking at the endometrium being good, no uterine problem. So really, we need to have so many ifs and buts even when you want to do fresh embryo transfer cycles. But then fresh embryo, because of all these things, on top of that, the gene expression things. So we look at the different gene expression pathways. Your HOXA10, HOXA11, which regulate the stromal differentiation receptivity. They are downregulated. Leukemia inhibiting factors decrease expression. Integrins are low or altered. Uh, Insulin growth factor binding protein 1. They basically look into the immune tolerance and the embryo interaction. They are disrupted secretion patterns are there. And your progesterone regulated genes are also different. So if your gene expression of endometrium, just because you're doing a stimulated cycle, is so very different, why not adopt to freeze-all for everybody? I'm sure these two things may not sync with a lot of people. People may say that, well, you have a good place of decreasing the time to pregnancy in a patient rather than doing freeze-all and increasing the cost and increasing the time to pregnancy. But all said and done, in my practice today, at all my places, we just freeze-all for everyone, and these are the reasons we do it. Uh, so ovarian follicles are available through the menstrual cycle. These are old studies which are done that they looked at the oophorectomy specimens and the luteal phase, the samples of that. And the famous study by Barber et al. In 2003. And he said about the follicular waves which are reported. And they looked in a study of 50 regularly menstruating fertile women. That's very, very important. They described the follicular waves in humans. It's the first study to describe that. The sample size was 50 women, and they were regularly menstruating fertile women. So there were no
Are you able to hear, ma'am?
No. Sir, we are not able to hear you, sir. Sir, excuse me, sir. We are not able to hear you. There is some voice interruption, sir. We are not able to hear you, sir.
Ma'am, can you try calling, sir?
Just give us a minute. Sir is just checking with his connections.
So you're on mute, sir.
Yeah, okay. So the follicular waves were described by Barwal et al., as I told you earlier, but remember it is described in regular menstruatal women and not in infertile women. They said there are three mechanisms of AFC recruitment. One is there's 1 minute, yeah. One is continuous recruitment, which takes place throughout the life, late luteal, which is very commonly known to all of us, and early follicular recruitment, which could happen in the early part. Wave of follicular recruitment means there is a synchronous growth of antral follicles at regular intervals when the follicles cross about 5 millimeters and start growing further. Two waves were detected in women with regular 30 to 35 days of cycle compared with one follicular wave in women with 26 to 30 days. So you have a shorter cycle, you will have just one wave. And all above is, so this is all supported by a lot by the evidence which has been published on serial ultrasounds and the inhibin levels as well. Interovulatory interval of two waves will be lower. Women who have two waves of follicular growth will have an interovulatory interval lower, that means smaller cycles, while with three waves, it will be a larger cycle, a longer cycle. So women with decreased ovarian reserve will have a shorter cycle, and hence they have the reduced fecundability and also inferior IVF outcomes independent of which. I'm just cross-checking. Am I audible and the slide is moving?
Audible, sir.
Hello.
It's clear now
Yeah.
and audible.
Yeah. I may just cross-check in between because the collection instability could be here.
Fine, sir.
Barwal et al. Group did not include the infertile women, nor they included the women with low ovarian reserve in their studies. But we keep applying their theories to all of our women. So, intraovulatory interval length is related to number of waves. Shorter will have single wave. And Barwal proposition actually may not apply to all of our women with diminished ovarian reserve. So, if we are advocating duostep for our patients of diminished ovarian reserve who have a smaller cycle and who have a shorter cycle and a single wave, I think we are going to be paradoxical. So this is what I understand from the physiological understanding. So then why do a lot of us do duostem or people advocate that? For basically two reasons. Time, faster time to accumulate embryos. That could be one reason. And time to pregnancy could be a little less. It's basically a time-related thing. So suppose you have women who are having oncofertility reasons or for their own shorter reasons, they want to complete the whole thing up faster. Well, a duostem makes a difference. Otherwise, if you from the result-oriented side, I would prefer to conventional to duostem again. Follicle waves can be detected. One measures a follicle beyond 5 millimeter and the dynamics of the human follicle between 1 to 3 millimeter, and their regression is really not understood to all of us. So what I want to say is throughout the menstrual cycle, certain antral follicles are available for you to grow and stimulate. So let's disarticulate. We'll have to convey this to our couple first, that your menstrual cycle is different, and that is very important and relevant to us because when we want to do an embryo transfer, because we want to put the embryo in the window of implantation. Ovarian cycle for controlled ovarian stimulation is separate, because that itself doesn't synchronize with the menstrual cycle. And we need more oocytes, more metaphase 2, more euploid embryos, and then more pregnancies. So let's disarticulate before we even embark onto IVF cycle for everyone. So shall we relieve the stress of waiting for a certain time to start stimulation? Why not start immediately? Again, there is an increasing demand of flexible IVF stimulation from the patient and the doctors. Why do patients need it? For oncofertility reasons, for social freezing reasons, and there could be NRI couples who just come down here for a few days and want to complete it up. Doctors, we need it because we want to do an antral follicle tracking in poor ovarian reserve patients. We want to schedule our IVF as per our programs and our embryologist availability. And a lot of times we convert an IUI to IVF or an IVF to IUI, and then we look into flexibility, and all these things are very important for us to make the cycle flexibility, and that really relieves us a lot of stress. Okay, so let's understand a different way we can start it off. So this is a typical late follicular phase start, wherein you're starting the cycle after the follicle is recruited, it's become beyond 12 millimeter. The slide is seen, and am I heard?
Yes, sir.
Thank you. So about 14 millimeter follicle. So with that follicle, you will have a few follicles, which are anything between 4 to 7 millimeter. Now, these are follicles where a majority of the receptors are FSHR receptors, and hardly 10% is LH receptor. So even if the LH surges, the follicle grows and ruptures. These follicles, which are very small, less than 7 millimeter, they are not affected because there are hardly any LH receptor there, and then forms the corpus luteum. So you can start stimulation in the late follicular phase, like I've put it in the blue. Start with your FSH or HMT or whatever you want to do it, and you will add an antagonist as the follicles go and become 14 millimeter size. You can add an antagonist and give a trigger. So you can start a late follicular phase. But I don't do this very frequently in my practice, unless the client arrives on day 7, day 8, and the client is then a polycystic ovary. Well, then I won't call it a late follicular phase because her day 2 and day 8 is the same. The follicle has not grown at all. So for a PCO, we have a huge flexibility of starting our stimulations on any day. But somebody who's normally ovulating, will I start a follicular phase, a late follicular phase? No, I like to manage it a little different way. So if I see a follicle of 15 millimeter and above beyond day 7, I would prefer giving a GnRH agonist trigger. What will happen? There will be a sudden surge of LH. You're inducing an LH surge. There will be severe luteolysis. The follicle will grow, rupture, and there will be luteolysis. Acute luteolysis will be there. By 4th day, your luteolytic effect is gone, and you can just start off the stimulation. And you can start the stimulation as of nothing has happened and go for 5 to 6 days. You can give a fixed antagonist also. You may not add anta. You can wait for the since you're in luteal phase. But believe me, this luteal phase is going to be very, very short. So probably you will end up adding anta very frequently after 6 or 7 days of stimulation this patient has received. So this is one other way of starting stimulation. Whatever LH has gone up has not affected the smaller white follicles because they're small, they don't have much LH receptor, and those follicles are not there. Rather, this particular trigger has created a good amount of LH pool for you to start the stimulation, and you're really starting the stimulation with good amount of raw material of LH produced androstenedione, which is a good raw material to produce estrogen. So this could be one way of doing that cycle up, and probably will be associated with better results. Like women, when you start your stimulation on day 2, if you're in a habit of doing FSH and LH, and by unfortunately the LH comes low, less than 1, how do you kick it off? This is one thing you can do. Just give a GnRH agonist trigger on that day. Take the LH up, and on 2 or 3 days you start the stimulation. You create a LH pool to start the stimulation. The same physiology can be applied here as well. What other alternatives we can have to this kind of a protocol? So you have a late follicular phase, just allow it to grow. You just start stimulation, allow it to grow, don't intervene, let it rupture on its own. But when you're starting your stimulation, add PPOS, do an PPOS stimulation. Don't bother about giving trigger or anything, and then you can smoothly carry forward and go as usual. Nothing wrong with it. So this is an Antonio Lamarca paper. He talked about this, and this is an evidence published that if the patient presents with follicular phase with a dominant follicle larger than 14 millimeter, we wait for a spontaneous ovulation to start stimulation or add a GnRH agonist to trigger, and then we can start off. So this has good amount of evidence for what I said to you. The other methodology is, you can suppose you're starting any luteal stimulation. So this is very typical. We start most of our stimulations nowadays go into luteal phase. So the red line indicates the ovulation has taken place. She is in the luteal phase, and in the luteal phase there will be an LH, good amount of LH in the early part of the luteal phase, and the progesterone is rising. With the kind of progesterone, your GnRH pulsatility has gone down, and GnRH pulsatility has gone down. That's why the LH is steadily maintained. There is no surging of LH which is seen. You can just start the stimulation. If you're starting in the early luteal phase, remember, the white follicles which you're seeing on the screen, a few of them are actual antral follicle, but few of them are atretic follicles. We attempted growth in the previous follicular phase, but now they did not become pre-ovulatory, so they're now atretic. So when you start stimulation in the early luteal phase, there is a possibility not every AFC will grow. So by the time you come to the dominant follicle size, the few atretic will not grow and your number of eggs will be less. So it's a very difficult scenario to convince our clients. Well, on the day of stimulation start, you will say, well, I'm seeing 7 AFC, madam, let me kick off. And you start the stimulation just to realize only 3 of them have grown by the time 8-9 days of stimulation over, and becomes puts us in a difficult situation of explaining whether we were right or wrong. But physiologically, this is a scenario. So I don't prefer starting any stimulations in this part of the story. I would rather go to the late luteal phase to kick off. So my preferred choice would be to go to late luteal phase, wherein your atretic follicles are gone, what you see is AFC, which has again grown out of the FSH, small FSH, which went up with your ovulation surge in the preceding cycle. So good amount of follicles are recruited. You look at the AFC and start your stimulation, and you can start whatever choice you have, FSH or HMG, you can start. This is my preferred way of starting. Now, should you add an antagonist? For example, suppose you see a corpus luteum. Should you add an antagonist first? And now it will be elagolix, adding elagolix 150 milligram, 4 to 5 days, and then starting stimulation. Uh, my answer is yes and no. Generally, I don't add any pre-treatment, especially to antagonists, because I'm a believer of giving more amount of LH activity there. So I will just start with the stimulation as it is. But then, see, I'm abroad today and I had to adjust few cycles earlier. So a lot of women, I put them onto elagolix tablet, especially the ones who are PCOS, a normal responder, so that I can schedule them whenever I want to kick off cycle. So that can be done here. Or if you're fond of using an agonist stop protocol, you can give an elagolix for a period of 7 to 8 days and, good suppression, get the AFC right and go ahead. But I see a lot of people using agonist stop protocol for women who have extreme low ovarian reserve, like women who have an AMH less than 0.5 or hardly 3 and 4 AFCC. In that scenario, accumulation of AFC may not be possible. Rather, you're suppressing the hypothalamic pituitary ovarian axis by using antagonists and then starting the stimulation. So even the true ovarian reserve, which as it is minimal in this particular lady, is not getting expressed very well. So this is one way of scheduling it, but you have to really pick and choose whom you will do an agonist stop protocol in your practice. Just because the literature says in poor ovarian reserve patients, agonist stop works, but again, poor ovarian reserve can be fractionated further with somebody who has a low AMH, a normal FSH, and young age. Somebody who has a low AMH, a very low AMH, let's say 0.5 low, but still normal FSH, and somebody who has a very low MH, FSH high and a higher age. So we need to fractionate it. We can't have a universal protocol of giving agonist stop to everybody. I think we will harm a few women, especially who are at advanced age and a very low ovarian reserve and a higher FSH. They may be affected. Now the question comes is whenever you do a late luteal start, shall you add an antagonist cycle? So generally in the whole luteal phase, you will not have a premature LH surge. So if the patient's stimulation spills over, she gets a menstruation halfway through, and your stimulation spills over in the next follicular phase, and your follicle size is beyond 14 millimeter, let it be day 3, day 4 of the cycle, of the menstrual cycle she got, you can add antagonists. But there is no much evidence published about when to add antagonists. A few papers say that you don't add antagonists at all. You say you add it. I think the evidence which has been published by the Spanish group, they say that all said and done, just add an antagonist at a fixed day because no great evidence is there of not adding an antagonist. Now let's move on further. Any questions here? Hello.
The conditions where you use agonist start-stop protocol, sir.
Yeah, I think see, I've started using it quite recently. It was not one of my one of my favorite ones. Like this time I've come to meet my children here, and all my cycles I needed to be scheduled. All my frozen ETs also, and a few of my cycles of stimulations also. So I did agonist. So I prefer giving elagolix. And beauty of elagolix is you can just start off on any particular day of the cycle. Like the patient has come to me on day 3. She wants to kick off a stimulation. I said, well, take elagolix for 6 days, and I'll start your stimulation after 6 days. Somebody has come on, let's say day 24. She's expecting her menses in 2 days, and I'm seeing a good AFC. I can start antagonist, then take it for 6 days and go ahead. If you ask me what I would prefer, estradiol pretreatment or elagolix, I would say estradiol pretreatment or any day. But estradiol pretreatment, elagolix is very good for somebody who's come on day 2, day 3. But again, I must say we'll have to individualize. It's better that this is done in normal responder, younger patients, and PCOS. Moment you put a lot of poor ovarian reserve and high-age patients in this kind of a group, especially using elagolix, you may harm the stimulation and the output. That's what my take is on that.
Okay, sir. So, and one more thing you said about luteal phase stimulation is after rupture, we can start. How long to wait before we start stimulation? Should we do any monitoring because the progesterone is going to be high, or we can just directly?
Yeah. Yeah, actually, I wouldn't bother much. I would just say, see, we don't call the clients every day. and starting random starts up for convenience also. So let's the patient has come in mid-luteal phase. I do a scan, endometrial mucogenic cake saying that progesterone is good, follicle has already ruptured. I may not even do any levels. I'll just look at the antral follicle count and start the stimulation off. I would just start it off because I'm in the later part of the luteal phase because the follicle corpus luteum is already. Especially if it is I'm in the mid luteal phase and above, I'll just kick off the stimulation. A good amount of progesterone there, and will not have a GnRH, but as I said, GnRH fertility will be low, so no risk of premature LH surges till the time she gets menstruation. So I'm okay to go with any kind of stimulation. I wouldn't even think PPOS. One can, but I won't think of it because nature has given some progesterone there. I would just start off the stimulation.
Okay, sir.
Now, a lot of this novel protocol demand addition of letrozole to our stimulations, and there's quite a mixed literature which has been published onto letrozole. Like now, if I speak to somebody or the colleagues, and most of them will agree that even letrozole addition in poor ovarian reserve patients will help us out because it increases the androgens levels intra-ovary, and the ovarian sensitivity to FSH will go up. And universally, all the evidence published is telling us that your gonadotrophin usage will come down. Suppose we want to use letrozole in PCOS. Some of us, like I don't agree to that at all. I say it's not one of those great things to do it. Few of them, like Dr. Anil Gudi, he says that if you have a very bad PCOS with a high AMH level, he prefers adding letrozole. He says that is one drug which can make it. He gives the letrozole with the stimulation through the cycle of IVF, and he finds that the response is better. So there are different views. So let's try and understand physiologically what letrozole science, published science or literature is telling us today. So letrozole addition in antagonist cycle with fresh embryo transfer decreases pregnancy rates due to high progesterone levels on the trigger. So letrozole addition is commonly associated with the high progesterone because letrozole backfires. It is an aromatase inhibitor. So there's a back accumulation and progesterone and pregnenolone goes up. That will come to secretion much faster than non-letrozole addition cycles. So this is one thing, the fresh embryo transfers may not be possible. LH is high in letro addition. Whenever you add letrozole, LH will go up because the E2 is kept low. The moment the letrozole action goes away, the receptors in the pituitary are hungrily waiting for the E2 to come there. In 48 hours, the E2 will go up, and that will and all the lysosomes or all the, vesicles or which are having the LH and FSH stored there are ready to be released, and there'll be LH will go up. But this high LH in the later part of the cycle with letrozole addition will select a dominant follicle because it will make the herd of follicle developing, but the smaller follicles LH will go up there, and that will make them androgenic milieu, and they may not become estrogenic. But a good follicle, dominant follicles will be selected better. So it will be better selection of dominant follicles. It will advance them faster, so better oocytes could be obtained and better embryos again. So this is a way the letrozole can act. And smaller changes in LH will have higher implantation rate. So if you have LH level maintained to a generally a good degree throughout the cycle, will have a better implantation rate than having sudden falls in LH. So these dynamics we'll understand through a few more slides again. Letrozole co-administration, sorry for the mistake there. Co-administration reported conflicting results on oocyte maturity rate and fertilization rate. And there's a decreased maturity rate with letrozole addition, which has been found. And many papers on onco-fertility are telling us this story. And there are many papers published like by Octet et al., Quinn and Jiang. And most of those papers say that follicle for growth requires a good amount of estrogen. Estrogen is a mitogenic hormone, and it is the hormone responsible for the growth of the granular cells. If you give letrozole and keep the estrogen low through the essential part of the follicle growth, will it affect the cytoplasmic maturity and the oocyte maturity therein? I somehow tend to believe into this concept. So I've not made letrozole part and parcel of all my stimulations, not even in my onco-fertility of breast cancer patients. I prefer, the first 5 days of breast cancer stimulation, anyway, the estrogen level will be less than 500 picograms. Only in the later part for 5 days, the estrogen will be high. So the lady will be exposed to a high estrogen for 5-6 days. The moment you do a pickup, immediately start letrozole 7.5 to 10 milligram, the E2 will drop drastically down. So just 5 days of high estrogen, I don't know whether it makes a difference. So you look at the onco-fertility papers published onto IVF done and a control group. the survival rate in the IVF rate and the control group is no different. Rather, the control group, sometimes the 5 and 7 year survivals are better. So to come to a conclusion that this estrogen will be harmful or will be propagating the cancer worst is no great evidence exists there. I could be affecting some basic concepts of people who practice oncofertility, but there's enough evidence published. We can definitely talk of oncofertility some other day. I'll send you all those papers. You can go through it. Not great evidence published that letrozole is a must. Rather, letrozole is a good paper published on letrozole during the course of stimulation, and they looked at the oocyte morphology, intercytoplasmic as well as exocytoplasmic. The p-value of 0.001 in all morphological problems increased. But sadly, that particular paper did not publish on the embryo outcome. So we have very half-hearted data there. So Octay suggested that letrozole containing cycles should trigger lead follicles with a larger diameter than those with traditional criteria, and that could achieve better results. Letrozole co-treatment decreases estrogen levels and accumulates precursors like progesterone, testosterone, and 17-alpha progesterone. And this microenvironment decreases calcium oscillations. It inhibits cytoplasmic maturation and reduces capacitation and thus fertilization potential. So I'm not one of those great advocates of putting letrozole into stimulation. Somehow I feel it's mixing of apples and oranges. All the interaction and all the debate on this is welcome. Because I feel herein you're giving more amount of estrogen because you want to give all the power to your granulosa and theca cells. And here you're taking a measure to decrease your estrogen levels. I really don't know how it works in nature. Letrozole decrease the HMG doses in low responders. This is very important, I feel. See, dose decrease. You just said the amount of gonadotropins usage goes down, so the cost goes down. But letrozole decrease the HMG dose in low responders due to its low FSH receptor expression because they're low responders. The FSH receptors are low, and letrozole will hasten them because androgens will increase the receptor expression. But in high responders, it did not make a difference because there is abundance of FSH receptors. So total dose difference was not realized in the high responders. What about letrozole co-treatment in PPOS? Just excuse me. Now, in India, and I think like China and India, we prefer mixing up a lot of things. And I'm sure you have a poor ovarian reserve patient, an advanced stage patient, you plan to do a progesterone prime, and you think, well, I want to use a letrozole also. So can I do it? I was just looking for an evidence, and this is the paper I got. Am I audible? Just a cross check.
Yes, sir. Yes, sir.
Yeah. I'm not trusting the USA internet. Okay. So PPOS we practice because it's safe, effective, no HSS, no LH surge, and similar to antagonists. Letrozole decreases HMG dose and same oocyte number in IVF. And let's combine both the beneficial effects. And this is a common thing which comes to everybody's mind. Poor ovarian reserve, advanced stage, PPOS, less cost, simple, patient-friendly cycle. Not much to be monitored here, and can we get best of both the worlds? So this is a particular paper looked into the PPOS data and the PPOS electrode. Look at the oocytes, embryos, HMG dosages were a little less. Metaphase 2 oocyte PPOS and electrode were lesser, and fertilization rates were also a little lesser. So they said metaphase 2 oocytes and fertilization rate decreased in electro added growth. So I go back to my electro theory that you are decreasing the estrogen level, and estrogen is essential for a good follicular growth. This is a beautiful paper. It talks about preventing growth stagnation and premature LH surge are the keys to obtaining a viable embryo in a monofollicular IVF cycle. Why I particularly included this paper was, but we want to know, many a times we'll have just 1 or 3 AFC, and we are stimulating these cycles. And we are thinking what different novel protocols we can use. Should we give a natural cycle? Should we use PPOS? Should we give clomiphene and HMG alone, letrozole? All those combinations are available. The ethos is that we want the follicle to grow, and we do not want premature LH surge because we want to control that whole event ourselves. I'm going to give you a protocol of how to do a natural cycle as well. But let's go into this particular paper and dwell into it further. It gives beautiful insights into our understanding. So what happened in the natural cycle? The LH levels continued to rise in the natural cycle. They were just not controlled because you never used PPOS, never used ANTA. So you want to do true natural cycle IVF pickup without giving any stimulation under the heading of minimal stimulation or the heading of embryo accumulation and making it as patient friendly as possible, then well, you can do it, but you have to be very about natural LH rise, and we'll come to that again. If you use ANTA, well, definitely the moment you use ANTA in any of these minimal stimulation, even if you're one follicle, the LH will be suppressed. PPOS, very peculiar. PPOS will have an early LH rise. And if you get very worried about this LH rise and then you are an antagonist, there will be a sharp decline in LH and there will be growth stagnation. I'll come to this growth stagnation. And clomiphene and HMG addition of an ANTA. So you can do a clomiphene HMG cycle and then you can add an ANTA because you want to prevent LH. Right? Again, there will be a sharp fall in the LH. But believe me, all these things we are looking into monofollicular development or just two follicles, 1 and 2, not even 3 and 4. So these situations do come to us and we really find what could be an ideal way of stimulating these particular lady or how should we take a decision. So look at this beautiful graph. They compared all the protocols. Natural cycle, look at the top red natural cycle, LH just goes up. Natural cycle, HMG and ANTA, the LH is still up but moderate. But movement, you're adding and CC, HMG and antagonist. There is a fall, a drastic fall in LH level. And if you're already doing a PPOS and HMG, in spite of the LH goes up high and you get worried and you add an antagonist, the LH falls sharper. And this sharp falls of LH may not be right ones, especially in a situation where you are monofollicular or just two follicle development. This may not matter much if your 10 follicles are equal to that. It may not matter. But when you have 1 or 2 follicles, it will matter a bit. So PPOS, in their comparative study of all these protocols which they studied, PPOS and HMG has the highest chance of viable embryo. It gives a clear idea. You have a low FC, don't get confused. Just put PPOS and HMG, and that has a very good chance of giving a good LH level and a high chance of viable embryo. So LH has a very dualistic attitude. So you need a protocol which can prevent an LH surge. And again, you want a protocol which can maintain a LH throughout the cycle so that growth stagnation is avoided. What do you mean by growth stagnation? After a certain growth of a follicle, it's a two-cell, two-gonadotropin theory. A certain amount of LH is a must because that will give androstenedione, raw material, more estrogen, and faster growth. If you cannot provide that LH during the course of stimulation, probably there will be what is called growth stagnation and poor oocyte outcome would be there. So LH below threshold will stagnate growth, and a certain high level in monofollicular development will be harmful. So this is very important word in this particular sentence is monofollicular. We have multifollicular development, and your FSH action is going on every day because every day you're doing FSH. There is nothing, no word like LH ceiling. LH can be any level because your aromatase is functioning very well. It will convert whatever androstenedione into estrogen. When you have monofollicular development, there is a limited aromatase action, and limited amount of aromatase is available, and that's where a certain amount of LH will stagnate. Will certain high level will be harmful. Upper and lower levels quantitatively have not been defined. Rather, it will vary from individual to individual depending upon their age, AMH, FSH, BMIs, etc. And probably some factors which we may not even understand, it could vary. So quantitatively, you don't know what is a high LH and a low LH in these particular scenarios, especially ongoing scenario. Like, based on day 2, you need a certain amount of LH. Like less than 1 LH on day 2, it's not a good way to start your stimulations. It's better we do a gas test, take the LH up and then, or add estrogen, make the LH up and then start stimulations. More and LH levels is more than the absolute levels during a stimulation, which can be any level. The dynamics of LH, whether it goes up and low, that is more important. That is more decisive about maturation of an egg or you not getting an egg, or etc. So an abrupt decline of LH will increase growth stagnation, as I told you, especially more relevant, especially when you have less oocyte scenarios are there, which is a great concern to all of us because about 50 to 60% of all our practice is about less oocyte patients. Diminished ovarian reserve with high age is a very tricky situation. Premature LH surge is high because the follicle has less number of granular cells. With less granular cell, less gonadotropin surge attenuating factor. So LH surge can take place at 13, 14 millimeter or maybe 12. And growth stagnation can happen if there is an iatrogenic severe LH suppression. So it's a very tricky one to manage in our practice. So going back, so this is we need to keep in memory of this, and suppose how will we act in a natural cycle then? I'll come to that particular take a little later. Give me one moment of that. What about clomiphene in IVF? A lot of us are in fashion of using clomiphene in IVF. So let's understand some physiological aspect of that. It has N-clomiphene and a zoo-clomiphene. N-clomiphene is 2/3, zoo is 1/3. I'm sorry, touching sphere off again. N-clomiphene is an E2 antagonist. It will go on the hypothalamus. More GnRH will be released, and that GnRH will stimulate release of not FSH alone, but FSH as well as LH. Later, this N-clomiphene has a half-life of 24 hours only. With positive feedback, the rising E2 should have a positive feedback on the pituitary, but N-clomiphene could be sitting there, and that is occupying the receptor, and that may not allow, that will allow like preventing the LH surge. But for that to occur, you will have to give clomiphene for 10, 12 days of stimulation. Let's say you give it only for 5 days. The N-clomiphene effect has worn off by day 7. Now E2 is going up, there would be LH surge. You want to give clomiphene for 10, 12 days, and clomiphene is occupying, it is giving the LH-FSH up, it is not allowing the E2 to sensitize positively the pituitary to give an LH surge. So it will act as a stimulation as well as prevention of LH surge. But what about zoo-clomiphene? So if you're using clomiphene and you intend not to give anything to suppress the LH surge, better use it for 10 to 12 days. What about zoo-clomiphene? It will act for 5 days. It will also occupy the receptor, but it will be an agonist to the estrogen receptor, so it will allow an LH surge. So clomiphene is also dualistic. If you have to give only, if you want to give it only for 5 days, your LH surge you cannot prevent. If you want to give it to prevent LH surge also and have an action, you'll have to give it for 10, 12 days. So, but again, LH suppression as it is not very reliable with CC alone. It could be a little reliable, especially when you use it for a poor ovarian reserve or advanced stage. It may not be very reliable for somebody who has a normal ovarian reserve. We just want to do cost saving give clomiphene. It may not, because they will respond very heavily. The E2 will be very high, and that may not be, that will cross over the inhibitory action and give a positive LH surge. Then, in a scenario like what is the best to deal with an increasing LH at the beginning of a surge? So what we are worried about, you're having just 1 or 2 follicles, LH can go any time up. So you're measuring them every day or alternate day. What action will you take? The one, if LH is escaping and the follicle is already beyond 15 millimeters, somebody who has monofollicle or 2 follicle, age is also high, just give her a trigger and aspirate that follicle rather than bothering upon the suppression of this particular LH. Only thing is, if you have multiple follicles, you have 3, 4, 5 follicles, they are growing up and LH is escaping well, then putting up an antagonist would be better. I don't like to add progesterone here. I prefer adding antagonist. And now elagolix makes the whole life very simple. Just 150 milligram once a day tablet I add, and then go ahead with the stimulation as it is. But whenever we are looking at the luteal phase, and this is one thing which is very worrisome to all of us, like today only, Dr. Shari was planning to start somebody in the luteal phase. She got a progesterone level done. It came something like 12, and and then we decided to do an HCG level, and we said we will, instead of luteal phase, we'll go to the follicular phase, crossover, and then start stimulating, because we would have high progesterone levels in the late luteal phase. And you're kicking off of stimulation, there's a possibility of a pregnancy already existing there, and that could worsen the OHSS. You're stimulating the follicle growth, and the pregnancy is giving HCG, and both can together worsen the case. And we are all going towards an OHSS free clinic, but luteal phase stimulation without detecting pregnancies will force us to face some OHSS in the future. Yeah. Now, I think whenever we talk of novel protocols and everything, it's all about different methodologies. Everybody comes and gives his own wisdom to the whole process. So many pre-treatments and so many kinds of protocol, and nobody says that I don't get results. Everybody in India keeps saying, well, I get good results and good results. But we can't have perfect guidelines, because we defined low ovarian reserve differently by 2011 Bologna criteria. In 2016 Posidon group criteria, again a definition changed. So the guidelines would be fluid, though the yesterday guidelines are not public. They're going to be fluid, and clinicians will have to make their choices. So understand the basic physiology and what we are doing and why we are doing is going to be very important before you really put in a practice of novel protocols in your practice. Let's go to this particular paper. It's a beautiful paper of minimal ovarian stimulation as an alternative to conventional protocols for older women according to postural stratification. And this is a nice group, actually, Causilino group. This is the ERA group of IVR Rama group, which is from Spain. They looked at the minimal control ovarian stimulation, and they chose only the group 2 and group 4. So all older women, both Posidon were chosen. And in minimal stimulation, they gave clomiphene 100 milligram day 2 to day 6, 150 RFSH or HMG. They used from day 4 onwards on alternate days. They gave antagonists. They added only when 14 millimeter above follicle was seen, and they gave a trigger, and they went ahead with the IVF protocol. And the other group was obviously conventional stimulation with 225 IU of RFSH or menopure and a typical antagonist added. Group 2 is going to be your client who are having a good ovarian reserve but beyond 35 years of age. Look at the choice toward minimal controlled stimulation. The minimal stimulation is 154 patients only, while 1,365 went for a convention. So whenever you see a good amount of AFC, irrespective of the age you want to go conventional, I think the world over, that's the practice which is followed, and we should follow that up. So looking at that. Look at group 4. In group 4, it's almost an equal proportion of women going for minimal stimulation and conventional stimulation. So I feel, well, minimal stimulation is something which can be applied to the group 4 because of multiple settings which they require. And the live birth rate, all the same. In group 2, 26.2 to 28.1, and group 4 is 11 to 11.2, which is amongst the minimal stimulation and conventional stimulation. The live birth rate did not differ in both the groups, but the cumulative live birth rate. Now, here, obviously, cumulative live birth rate is similar, like exhausting all the embryos you have transferred. And obviously, that would be higher in group 2 because they are the women with good ovarian reserve, and though that would definitely make a difference of giving a better cumulative live birth rate to them. So again, when we discuss novel protocols and we argue amongst each other that this works better than this, we must have this bottom line in our brain. That if we transfer one good quality blastocyst of whatever stimulation protocols, your clinical pregnancy rate and live birth rate is similar. And there is something called ovarian oocyte sensitivity index. And what is that? Oocytes who respond to lower dose of FSH are better oocytes. The other oocytes who give their BMP and GDF factors early, they grow in a better environment, they become more mature, better embryos, better blastocysts, rather than the oocytes who require a high dose of FSH. So by increasing the FSH level, by giving small amount of exogenous stimulation, let it be letrozole, clomiphene, or low dose, if you're able to recruit those few oocytes, they are going to be one of the best oocytes. And if you give a high dose and if you put many more oocytes, there would be a bunch of oocytes which are good and bad put together. But not, I would say, bad. They're having less cytoplasmic maturity or asynchrony, you could be in my report. But then we need to translate this into our counseling skills before embarking on IVF. Well, there's a client in front of you who's telling, doctor, please come down on the cost. And there's a client in front of you who's saying that, well, I want to complete the family. The one who says, please come down on the cost, you'll have to just tell her, well, I'm going to give a lower dose to you because I'm giving a lower dose, you'll have less oocytes. But still, whatever oocytes I obtain, I'll obtain the best blastocysts out of it. And then your pregnancy rate is going to remain the same. But all that is possible only when those cycle cancellations are least. So in your individual practice, you have to identify your novel protocols where you face cycle cancellations often. If you face cycle cancellations often, that protocol is not something to be followed. Because cycle cancellation is also a very good success parameter. You should have least cycle cancellation during the course of stimulation. So maybe if you're not feeling very confident, you can always say, well, there is a possibility, a very small possibility of cycle cancellation. Giving a higher dose will definitely better. Your cycle cancellations will be less, and going ahead would be. So we need to translate this with the client into counseling, whether the client has come for one baby or they want to complete the family, or they're looking at cumulative, they're thinking with you in looking into cumulative live birth as success parameter, and not just one baby. Now, what about controlled ovarian stimulation of a dominant follicle using progestin in minimal stimulation in poor responder? A very interesting one. They looked at the data they looked into. Mean age of the group has been 37 years. So some of them must be 35 and some must be 40 as well. Mean FSH 11.5, AFC just 2.2 in either groups. And herein, it's a beautiful way the materials and methods are telling us how to do a natural cycle IVF, and that's how I picked it up. Take a day 2 scan first, see the ovaries are quiet. If there's a residual cells, don't do a natural cycle IVF in that particular cycle. They do a day 7 scan then. Once the size of the follicle is 13 millimeters, scan every day with LH levels. Once the follicle goes beyond 18 millimeter, no LH rise, trigger with decapeptyl in the midnight and do a pickup. Okay. And obviously start 600 milligrams ibuprofen on the trigger day as well as the next day, opioid at 30 to 36 hours. Sadly, if the LH has gone beyond 20 and the follicle is 17, 18, just give ibuprofen, no trigger, and you do an OPU at 28, 18 to 30 hours. And you will say, let's discuss what time, 24 hours or 26 hours. Don't give us such a big range. But there has to be a big range because no embryology lab works in the midnight. So everybody will target their pickup the next day morning, the earliest morning when the whole team is available. So this variation in the data is quite acceptable. In the other way, this was the natural cycle IVF, in which they compared to the MPPOS. On day 3, they started medroxyprogesterone acetate, 10 milligram. They did a day 7 scan. And when they looked at a follicle which is going 7 millimeter and the heat was risen, they said that this is the follicle, we want it ahead. And then they added HMG, 150 IU daily, and obviously the PPOS medroxy continued, and they gave trigger with decapeptyl. So, we feel that moment you start medroxyprogesterone D2, you are not going to have any follicular recruitment. That doesn't happen. It suppresses LH first, but FSH will be still active, and some follicle which has been recruited before -3 days or -2 days with this FSH which is rising there, and these will be typically low ovarian reserve. So FSH is decently gone up. The FSH threshold of the follicle is low. So probably many of them will have a 10 millimeter follicle more on day 3 itself. So you will have that opportunity of adding HMG daily and taking that follicle further, like a PPOS, and giving a decapeptyl. And what they found? More oocytes, more embryos in the MPA group, and avoiding spontaneous LH surge. So a lot of patients in the natural cycle did have almost about 50% of the patients belong to this particular group where the LH did go beyond 20 and they had to suddenly do and pick up for them. So can we add clomiphene to PPOS? What should be a take? Like we studied about letrozole to PPOS. So can we add clomiphene to PPOS? In younger, diminished ovarian reserve women, LH was better maintained with clomiphene and PPOS. PPOS will suppress LH because clomiphene will give some LH up because of the stimulation. So LH will be better maintained and they would have more embryos and lesser HMG doses. In older women, there will be high LH of CC and there will be low maturation rate. See, the number of eggs are going to be different. In a younger woman, we'll have a little more eggs. The LH, maintaining LH will do good to those eggs. In older women, less eggs, LH ceiling will be, high LH will be detrimental and low maturation rates will obtain. PPOS alone is much superior to clomiphene primed ovarian stimulation alone in older women. So I think sticking to PPOS with HMG makes all the sense to all of us. But what we need today is a prospective study. I'm not putting RCT. We can do an observational study, all of us together. A prospective observational study of clomiphene in PPOS protocol in Posidon 3 and 4 population. If we can just accumulate the data of our own, I think that would be one prospective study. Because there's no data exists on this particular thing. Most of them are retrospective studies. They're not looked at the whole data prospectively. Well, thank you so much, Vasundara Madam, Scale team, for allowing me this presentation. There are some evidence papers which I have not dealt with them today. As I told you, it was going to be a little heavy for me to come to the whole thing. So I'll do that up next time if an opportunity is available.
Thank you so much, sir, for spending your 1 hour time from New York to teach all of us. There are a couple of questions in the chat box. I would first request you to take those questions, sir. The one question is like whether high levels of progesterone and low levels of LH on the day of trigger, despite good follicles on scan, can it affect the oocyte quality?
So high level of progesterone 26, he says, and LH 0.01 on trigger day, good follicles, can it affect oocyte quality? No, actually, no. Rather, I don't know what responder she is, but with the fact that progesterone is 26, I expect her to be a normal responder or a high responder. In this particular scenario, rather you will land up getting more mature oocytes. Because why the progesterone should go up in a follicular phase? Progesterone going up means the follicle has reached the pinnacle of maturity. That means your aromatase action is completely taken over. The raw material is extra, but there's no much aromatase available to convert the raw material of androstenedione into estrogen. So it backfires. So you have your progesterone and pregnenolone going up, and progesterone more in the theca, so enters the circulation and your progesterone level goes up. So it's a completely LH independent progesterone rise. It could affect the endometrium, but will never affect the oocyte. And rather you'll have a bet. Like give me an example. Let's say you're in an egg donor cycle. You have an egg donor cycle, progesterone on the day of trigger comes, let's say 0.1. I would say let's give me stimulation for 1 or 2 more days, take it to 1.2, 1.3, and then give trigger, and probably I'll have more metaphase to oocytes.
Thank you, sir. The other question is, many IVF specialists don't check hormonal levels. How can we make out low levels of LH?
You must check, because I'm not in sync with people who don't check at all. Because see, it happens even in my 25 years of practice. It has happened for 15 days or 1 month. I've not got any results. How do I audit myself? How do I maintain the KPIs for my embryologists? How do I maintain KPIs for clinicians? Whether they've taken correct decisions or no. I think hormonal monitoring, a thorough rather than extra hormonal monitoring, is a must for all our, because it's a continuous process of learning. So without hormonal monitoring and presenting that data, even if you tell some colleague that, well, I've not got the result for 2 days or 2 weeks, that colleague will not be able to solve your problems. You're not giving any hormonal data to them.
So we were talking about very low LH levels, especially, sometimes after we start antagonists, maybe, when we are monitoring, the LH levels are very low, like, say 0.2, 0.3. So can we skip one dose of antagonists, because sometimes there can be follicular stagnation, is what you were saying. So is it a wise or we just continue?
Number one, I agree to that. But there's no much evidence published onto antagonist posting kind of stuff, because it's just more of a logical and intuition-based decision which is there. So rather than that, why not add antagonist only when the LH level goes beyond 6? So keep monitoring. Only if the LH goes beyond 6, you can add antagonist. You can do an alternate day monitoring. Let's say it happens that today you did an LH level, it's day 8 of stimulation, it comes 4, so you don't have to add anta. Call the patient day after tomorrow and do an LH level, it is 17. So, you missed the yesterday's, right? It's okay. You start anta now, and in the next 2 hours, the LH level will fall. At least the follicle will enjoy all the raw material produced out of LH. So we should not get worried about all these things.
And what about on the day of triggers, especially in hyperresponders and PCOS, your LH levels are low. So we are a little worried about adding a small dose HCG. Should we still add because?
No, I think both are different scenarios. Number one, uh, HCG is a LH surrogate for search. It is not going to give a raw material to form the follicle better. Okay, so I'm not in sync of that kind of a story of this. We have come to a conclusion that we must maintain a decent LH level through the stimulation. But that's more relevant to all of us. So, going with FlexiStart, just adding Elagolix, 1 tablet a day, I think that has made our life simple. Or giving low PPOS with micronized progesterone has made our life very simple. We're very happy with. We were not so happy with PPOS with 10 milligram MPA. We're very happy with adding a micronized progesterone. It maintains a decent LH level through compared to a over suppressed level with MPA as well. So maintaining a good LH is very important through the stimulation, I feel. And again, if you use Menopure, don't even bother about LH levels, because Menopure has HCG.
HCG, yes.
There. And if you do an HCG level on the day of trigger, it will come 5 or 6 units. So one HCG molecule is 7 units of LH. So that means 5 units will be about 35 units of LH activity there. So if you're using Menopure in a stimulation, don't bother about LH at all.
Should we also measure FSH on the day of trigger, sir?
Interesting question. Not much has been described on that, but I prefer measuring FSH on the day of trigger for everybody, all my patients, because as I said, a lot of my patients are going to require multiple stimulations. And whenever there's a multiple stimulation, they're going to ask me one question: in my next stimulation, what dose will you be using and will my cost come down? And they're not interested in 10,000 rupee discount. They want 40, 50,000 rupee discount. One, that's a practical thing. The second is you go and you go through the whole stimulation. You feel you're done perfect, and you have 10 follicles seen, 2 eggs obtained. And then now the client is asking, doctor, should I use the higher dose for me? So doing an FSH level. So I'd like to maintain my FSH level beyond 18, MIU. If it is between 18 to anything further, I'm happy. That means my dose and the duration has been perfect. I've reached a good amount of FSH. Then I become more answerable to the client very well, very clearly. And then they're very happy about, doctor has taken every care. And in spite of that, then they're able to accept their destiny. Otherwise, they will never accept their destiny at all. Like today's morning speak up. This patient, we had an empty follicle syndrome last time. No eggs obtained. me and Sherry were completely devastated. But we spoke to the client. We said, we did everything possible for you. We chose the correct dose, duration, correct drugs. We measured FSH level, measured everything. Not empty follicle. She had a premature ovulation. Sorry. She had premature ovulation on table. And then she stuck to us. Fortunately, after 2 months, she came back for a second cycle. Again, everything we did perfectly. Today, they got 19 oocytes, 16 metaphase 2. We are happy. We are through the cycle now. So measuring FSH gives us a lot of power to audit ourselves, and also, suppose I do everything, like I do HMG, and my FSH goes 8 on day of trigger, 8 MIU, and I get 10 oocytes and 3 embryos, and the client wants one more cycle. I would have to convince them, please use RFSH, because with HMG of 300 IU, I could not reach a good FSH level for you. So I measure FSH for everybody.
So if the FSH is low on the day of trigger, say, as you mentioned, so you will continue.
No, that's something to be audited retrospectively. This is nothing, no prospective measures are possible. Prospective measure is possible in the next cycle.
Yes. Thank you, sir. So, and also there is a question that giving alternate day HMG during ovulation induction, will it work the same as giving daily? Practically cost saving, alternate days of HMG are given in good pregnancies.
All these papers have typically come from China and India of giving Kuang, especially after Kuang's paper, they alternate day HMGs. See, you look at the patient scenario. Here is a patient who has 1 or 2 or 3 AFC, AMH is pretty low, and you're taken FSH high. When the AMH is pretty low, that means the FSH threshold is also not great there. Any rise in FSH is going to stimulate those follicles. So I don't think it would make much of a difference. In my practice, I would prefer daily rather than alternate day, to be very frank, because with IVF, we and patient both are serious and they don't mind taking daily injection. It's a norm all over that daily injections is a norm and consensus understanding. So I would prefer daily.
And the difference in the endometrial quality with clomiphene and letrozole, I think it's a...
I think from the IVF point of view, none of us use clomiphene for endometrial preparation or clomiphene-induced cycle. We do fresh embryo transfer cycle. So I don't think hardly any data would be available. We need to look into papers. From the ovulation induction point of view, if you look at the papers published by Richard Legros of clomiphene and letrozole for PCOS, the first paper, still said the clomiphene endometrial thickness was good compared to I'm sorry, I'm quoting the wrong paper. Clomiphene versus metformin, the first paper published. Clomiphene one group, metformin another group, and clomiphene metformin together in one group, published almost 15 years back. The clomiphene endometrial thickness was better. Okay, then they compared the letrozole clomiphene and Amigos study. On PPOs. Again, the endometrial thickness was good. There's not much statistically significant difference. Only when you use clomiphene and HMG together and letrozole and HMG together, there is a possibility of endometrial thickness being different. Clomiphene endometrial problems is an idiosyncratic reaction. I think the only history I ask my clients is, when you received clomiphene, did you have scanty menses? If you had scanty menses, that means I'm not supposed to use clomiphene again for her. Otherwise, I'm not much bothered about it. Otherwise, the whole literature would not have enjoyed so many clomiphene pregnancies over the last 6 decades.
So what are the must hormone monitoring in a cycle, and what is a decent level of LH that you recommend we have to maintain throughout the cycle?
See, if you have a basal FSH, LH, and AMH levels, I won't like to measure any start day levels. But if your patient has taken OC pills, has taken GnRH agonist in the past, or something like that, then I would prefer measuring LH level on the day of stimulation, because the LH is less than 1 or less than 1.5, I would say. It's worth doing a CAST test, that is, you give a gonadotropin, give a leupride, take the LH up, and after 48 hours start stimulating. So create a LH pool, or give estrogen, Proginova, 8 milligrams, or 6 to 8 milligram a day for 8 to 10 days. The LH will go up and then start your stimulation. So that's one. Second, I prefer doing a monitoring on day 6 of stimulation. I do an LH and E2. I do FSH also. Don't go by me here. It's just out of data keeping. I do an FSH also, because I want to see a trajectory of FSH. This is going up. And then I do LH and E2. Sometimes the E2s are very high, like 800, 1000. Then I would add a fixed antagonist. If the E2 is moderate, let's say 600, and LH is also less than 4, I will not add, less than 6, I will not add any antagonist to them. Then I call them alternate day. If I'm not adding antagonist, I'll call them alternate day to look at the LH levels again. Okay, and the moment the follicle size goes 13, 14 millimeter and above, or the LH goes beyond 7, then I add my antagonist dose. I don't titrate in antagonist. There are some people who titrate the antagonist as well, because it comes from the literature, but I don't. It's too much of titrating, then it becomes very individualized. Then you have to intervene into every client, and you can't have a team of doctors individualizing and syncing with you together. So you need to have certain policies. So I don't titrate my antagonist, give 0.25 to everybody. On the day of the trigger, again, it's FSH, LH, progesterone, and FSH, your E2 levels. And if I give GnRH agonist trigger, after 12 hours, LH and progesterone levels. And if I get less amount of eggs on the day of pickup, I will do an HCG level. And my HCG is strict, I will do an HCG level at that point. So this is the way we monitor our cycle.
So whenever there is a elevated day 2 FSH levels, sometimes, there are papers which are advocating follicular antagonist for, but then when I have tried in my stimulations, I have not had good outcomes. So I have stopped using it. So should we use it just?
That's a very important question, I would say. So let's talk of a young lady who has a low AMH and a high FSH, and a young lady who has a low AMH and a normal FSH. What does the FSH indicate? Let's say I have a lady who has an AMH of 0.8 or 1 and an FSH of 12, and I have a lady of AMH of 0.5 and FSH of 7. I would love that lady with 0.5 and FSH 7 than the FSH of 12 and AMH of 1. Because AMH is a global picture. It is just a global picture of the granulosa cells secreting AMH in the systemic circulation. You are measuring that. You don't know which follicle, which ovary, you don't know anything. It's a global picture. But the FSH is definitely going up because of lack of inhibin. Inhibin comes from granulosa cell. That means there are less granulosa cells. If there are less granulosa cells, that means your oocyte nutrition is going to suffer. And if your oocyte nutrition is going to suffer, you're going to get oocytes with less maturity, or I'm wrongly using the word maturity, less competence. Okay, so I feel going on high FSH, it just tells you that this particular lady has a high FSH, I'll just pump in more doses. That's all. That's all it is.
So people who use Menopure, this question may not be valid, but there are some protocols where they use low dose HCG for either stagnant growth or in hypo patients along with HMG. So is it really beneficial? What is your
even I do HCG in my hypo patients, or women who consistently have low LH levels, and sometimes it is really unexplainable why they are having a low LH levels. I've got stuck with some clients like that. So what I do is I've given them about 1,000 IU HCG per week for about 3 to 4 weeks before I embark onto stimulation. So I prepare a LH pool. I push the follicles into preantral zone, like grow, like help them grow from the primordial further. I agreed on primordial follicle to preantral follicle is almost 180 days. You're not going to give 180 days of stimulation. But whatever follicles are in between will kick off. Your AFC definitely improves by 1 or 2 here and there. And then I kick off my stimulation from that day onwards. Now, whether you can give a low dose HCG, my issue is physiologically, yes. Shall you give it? Yes. All agreed. You can give it through the stimulation, you can give it later on. My problem is the jugaad of making it. That's my problem. So suppose you land up giving more HCG as a jugaad compared to the FSH dose, probably you will end up suppressing the whole event. So because of the jugaad involved, I'm not into that practice. Rather, I use 75 of Menopure there, instead of doing all the jugaad. And we used to have an orbital pen earlier, but sadly we don't have it anymore. And on one side, we top of our Indian HCGs and Indian HMGs to be having a lot of biological variability. And we try to lessen the dose and start using it, saying that we are perfecting the science. I think it's a paradox. Just because of jugaad, I'm not in favor of that.
Thank you, sir. So in PCOS, as you were saying, that there can be a little bit of LH surge even on day 4 or day 5. So in that scenario, is it worthwhile starting them on an antagonist on day 4 itself or day 5 itself? Because day 6 weight might be like sometimes 1,000, 1,500.
I do perfectly agree on to that. There's nothing wrong in a PCOS to call them on day 5 itself. And irrespective of the size of the follicle, if your E2s are going up, beyond 1,000 or your LH is going beyond 9 or 10, better to add antibodies. No doubt about it. I totally see. Herein, the size of the follicle wouldn't matter because they will have a slow growth because of high MH. So, okay, absolutely okay with that.
Thank you, sir. So wonderful lecture, sir. What is your opinion about growth hormone and its use in stimulation protocols?
I think I truly believe into growth hormone. I would love to use it and experiment with it more and more, but unfortunately, the cost really hinders the whole thing up. And that is one interesting introduction I feel in the protocols where in the past the client has not given good number of mature oocytes or the embryonic quality has been very poor. That's a very physiological introduction to the science of ovarian stimulation because growth hormone IGF makes a difference, all the difference in giving a better quality and better competent oocyte. The question which I face is when and how much and which particular client, because if you go to the systematic reviews been published over last 1 decade, everybody is saying growth hormone is wonderful, but they used high doses, like something like 12 IU, while Indian scenario only 4 IU is available. There was only one Chinese trial which I used 4 IU, and that's why I'm saying, well, there is some evidence published. I use 4 IU in my population. There's a Norbert Gleicher paper which is published about why not do a growth hormone level, IGF-1 level, before you take a decision. So if you already have an ample IGF-1 level in patients who have advanced age and poor ovarian reserve, don't add additional growth hormone. It's not going to make any difference. Rather, addition of growth hormone. If you add a lot of growth hormone there, that will decrease your IGF binding proteins will come down, and somehow there will be insulin resistance to the trophoblastic cells, and your miscarriages will go up. It's a very interesting paper he published. So that when you read the literature, it is a bit confusing. So I pick and choose to add my growth hormone. But nowadays, me and Dr. Shari, we prefer doing growth hormone levels, and we educate our clients adequately, and then only we put out the growth hormones. Not a universal thing, and we don't create a rosy picture in front of our patients.
So the labs do the IGF-1 levels, sir?
Yeah, the labs do IGF.
And what is the cutoff, sir, we take?
Very interesting, Vasundara. Very, very interesting. Because when you go to the Norbert Gleicher paper, what he did was he did about growth hormone IGF-1 level for his population. I forget the exact number. Shari would probably remember that. And then he looked at the 10th percentile, and that came 138. And he considered 130 at 10th percentile. Anything less than 10 percentile, he labeled them to be low. And then he analyzed the data. In the next group of clients, he supplemented growth hormone to somebody who's having less than 138. Now, we don't have a nomogram. So I'm blinded. I'm just going by the Norbert Gleicher study of cutoff of 138.
And I'm not sure whether it's going to vary based on the BMI of the individual also, the nomograms.
No, I must say I have no knowledge on that particular aspect. We need to speak to an endocrinologist or read something more on that.
Thank you so much, sir. You've been with us for so long. There are so many questions pouring in, actually privately on the WhatsApp group also. So I would take all these questions and share it with sir, so that, this is a topic so vast and you've made physiology so interesting for all of us, sir. I would really thank
I don't know if it's interesting.
Definitely, sir. Definitely. If we read the books, we would, probably doze off. But from learning from you is always a pleasure. So one last question from my side, if you permit me, is is there any trigger criteria that differs based on the protocol? Say in PPOS, you would want to wait a little longer compared to your antagonist protocol or this thing. Is there anything like that?
Trigger criteria. I think we can't have so many confounders without telling us when to trigger. I feel the best confounder, which I still follow, is if the whole herd is beyond 17 millimeter, and I still follow the same confounder. The second is a very low ovarian reserve women. Then sometimes the LH starts, in spite of you giving antibodies, the LH starts going up when in low BMI and a low reserve women. In such women, I just give trigger and come out of the client as fast as possible. Otherwise, not much difference I do in those protocols as such. I think next session, I would love to do a session on exactly using a protocol.
Yes, sir.
I would love to. I'm going to share an experience of giving a novel protocol. We are giving intradermal FSH to our client. Done about 16, 17 patients. But I would just like to share it up. Basically, sharing it up so that I want to invite criticism on all to that, so that we improvise and whether we should follow that up more or we should not. to do that. Yeah.
Thank you so much for your enthusiasm to teach all of us. As always, we are very obliged and honored to have you on this platform. On behalf of everybody from the scale and all the delegates who have stood with us till now, we extend a wholehearted thank you, and we will come back with Sir's lecture definitely soon. Thank you so much, sir. And we would like to see all of you in the next masterclass on 14th of August. Thank you, everyone.
Thank you. Thank you so much.
Thank you. Thank you so much.
Thank you, sir.